My name is Karen Harrington. I am Director of Scientific Affairs at Hologic. I help to support our virology portfolio of assays, and today I am going to talk to you all about what I consider to be an incredibly important public health topic, which is hepatitis C virus, and the goals and the path toward HCV elimination, and the role that HCV screening and testing will play in helping to achieve this goal. So hepatitis C is a viral infection that can cause chronic liver disease, and hep C infection can be a bit tricky in that many people with the virus do not experience any signs or symptoms of the disease until it's progressed to an advanced stage, which can be decades post your initial exposure and infection. HCV is a blood-borne virus. It's transmitted through sharing needles, syringes, or other drug injection equipment. It can be passed from mother to baby during pregnancy or at birth. And rarely, but on occasion, it can also be passed through sexual contact or by sharing personal items that may have some blood contamination. More than half the people who become infected with HCV will develop a chronic infection. And untreated, chronic infection can result in serious disease and long-term health problems, including liver damage, liver failure, cirrhosis, liver cancer, and even death. It is the most common reason for liver transplantation here in the United States, and HCV is associated with more deaths than the top 60 other US reportable infectious diseases combined, including HIV. So, why the focus on HCV? Why the focus now? It's estimated that nearly 2.4 million Americans are living with hepatitis C, and up to 50% of these people do not even know that they are infected. Cases are on the rise at an alarming rate. And although there's currently no vaccine available, there are excellent medication and treatments that result in an extremely effective cure. So as mentioned, cases are rising at an alarming rate. In fact, the number of reported and estimated cases have doubled in the last 10 years. And reported cases continue to make up only about 7% of estimated cases. And this is a huge disparity. So many people have traditionally thought of hepatitis C infection as something specific to only the baby boomer population, so people that were born between 1945 and 1965. But as this data shows, you can see that is no longer the case. Things are definitely changing. The rate of new hepatitis C cases reported to CDC among people 18 to 40 years has increased steadily since 2013 to nearly 3 cases per 100,000 in the population. And the most rapid increase in acute HCV incidence has been in young adults, age 20 to 39, in people who inject drugs, with increases in both males and females, but more pronounced in males. Rates have also been increasing in American Indian, as well as Alaska Native and non-Hispanic white populations. So organizations that develop and issue guidelines, like the US Preventative Services Task Force, the Centers for Disease Control, the American Association for the Study of Liver Disease, and the Infectious Diseases Society of America all recognize that screening individuals for hepatitis C, that healthcare providers can then identify the infection early and provide treatment that can prevent or delay the development of serious liver complications. And as we see here, these guidelines were updated relatively recently. The USPSTF and CDC updated their guidelines in 2020, and the AASLD, as well as IDSA, updated guidelines in 2021. And these have really changed then, so rather than focusing on the baby boomer population, the recommendation now is that all adults age 18 and older should be screened at least once in their lifetime. Pregnant persons should be screened for HCV with each pregnancy, and persons at any age that are at high risk, and some of these risk factors could be people who inject drugs, people who are HIV positive, men who are having sex with men, should undergo regular screening for hepatitis C. In fact, AASLD and IDSA even recommend that this screening be opt-out screening, and that it is annual for those with high risk factors. And any person who requests a hepatitis C test should receive it, regardless of their disclosure for risk, because many people might be reluctant to go in for testing if they have to disclose these stigmatizing risks. So what is the rationale then behind the expansion of screening and testing for HCV? So as we know, cases are on the rise, especially in the younger adult population and in high-risk groups. And with the approval and availability of pangenomic direct-acting antiviral medications, or DAAs, that have been available since 2014, these have demonstrated excellent safety and efficacy with cure rates greater than 95%, which is much improved from their prior interferon counterparts. And as often that does happen over time, the cost for these DAAs have been decreasing, making this treatment more affordable and more widely covered by private insurance, as well as covered by Medicare and Medicaid. And decreasing hepatitis C rates mean lower rate of liver cancer, lower rates of liver-related mortality and mortality overall. And lower rates of HCV also mean less transmission, much like with HIV. Undetectable means untransmissible. So this means less progression toward disease, lower mortality, and overall significant healthcare cost savings. So how do we get there? We've got goals. When we expand screening and testing and get infected people on treatment and cured of HCV, we can eliminate HCV. In fact, very timely for our conference this week and this session, the Biden administration had a new proposed budget to Congress, which was announced last week, seeking to expand hepatitis C screening, testing, treatment, prevention, and monitoring with a $5 billion plan to end hepatitis C nationwide by 2030. And this plan includes a comprehensive public health effort to engage, to inform, identify, and treat people with hepatitis C, and could really help to invigorate and continue to support efforts for elimination. So our goals to eliminate hepatitis C as a public health threat begin with awareness. It also begins with testing and identifying those people who have HCV infections. And in many ways, it really begins with all of you. It begins with public health, and it begins with public health laboratories. Public health labs are the foundation and the critical partner to our communities. They play a key role in increasing HCV testing and awareness within our communities. Public health labs can work with local health departments and healthcare providers to increase awareness about hepatitis C testing and encourage individuals who are at risk to go and get tested. Public health labs can offer a range of testing options, whether these are traditional or rapid tests, helping to increase access to testing and reducing the number of people that go undiagnosed. Public health labs can collaborate with community-based organizations and other stakeholders to increase testing and ensure that people who test positive go and get treatment. Public health labs can provide education and training to healthcare providers on how to identify people who are at risk for hepatitis C and how to test for the virus. They can also provide education directly to people, making them aware of their need to go and get tested and treated. Public health labs can adopt new technologies, such as self-collected samples or alternate sample types, which can then be sent to laboratories for analysis. And public health labs can help to seek additional funding to support Hep C testing and treatment options. So when we talk about hepatitis C testing and what does that exactly mean? So most of you, I'm sure, are pretty familiar with the testing algorithm from CDC that's also supported by APHL. And for Hep C, it's really a two-step testing algorithm. So first, you have a screening test. This is done by serology. And laboratory screening does detect the presence of HCV antibodies. However, if you have antibodies to hepatitis C, this does not exclusively mean that the person has an active infection. It is possible, and some people do spontaneously clear HCV. So a positive antibody test can mean either active infection or can mean prior exposure and prior infection. Following serology, a diagnostic laboratory test that detects the presence of Hep C virus in the blood, typically done by HCV RNA nucleic acid test, provides confirmation of whether or not an individual has an active hepatitis C infection. And approximately 50% of people that are positive by the antibody test are likely to be positive by HCV RNA. And of course, this is going to be dependent on the population of people being tested. So the process from testing to treatment is really a multi-step process. You have one test or one step for the antibody screen, and if it's positive, then you have step 2, which is running an HCV RNA test to confirm the active infection, and then get a third step that is typically needed to link patients to care. And we know that the more complicated and the more steps that are involved in trying to get from test to treat, the greater the chance of we have at losing people at any point in this process and actually getting them from linked into care and treatment. So when we think about what we need to do to sort of meet challenges of screening and testing people for HCV, it's really thinking about what is the right test done at the right time in the right place. And what changes perhaps might there be for us to consider with screening and the diagnostic algorithm that can improve the current process and increase our chances for success? So the first thing is looking at automatic reflex testing from antibody testing and serology into HCV NAT. And this can be done in multiple ways. So this could be either a multi-tube collection at the single visit, where you have 2 tubes of blood that are collected from the patient, one that's going to be going for the initial antibody screen, and then the second tube that can be reserved if that antibody screen test is positive. The second tube can then be reflexed to the laboratory for HCV RNA testing. Or this might mean a single tube that is collected from the patient at a single visit that can be sent initially for antibody testing and then reflexed to the lab for HCV RNA testing. And what's really critical here, though, is that we're trying to reduce the number of visits required for the patient for the testing. So if we can get that to a single visit, that is what's really critically important. And if auto reflex testing is required, I think it's important that we consider whether it's best to have facilities and laboratories that are performing both the serology testing as well as the HCV RNA testing. This really helps to facilitate a quicker turnaround time, less likely things that might be lost during transport. You have appropriately trained staff from the molecular laboratory that can help to train some of the staff in the serology lab as far as cross-contamination risks and things like that. So having all of this testing under one roof would be extremely valuable. We can also consider a change to the existing algorithm that would be a one-step test and looking at utilizing HCV RNA testing as the first line for screening and diagnosis. Currently, none of the FDA-approved assays for hepatitis C have this indication. This is something that would need to be considered for the future, but certainly could result in some improvements when it comes to reducing the time to diagnosis, reducing the loss to follow-up, faster time into treatment, and I think then we'd have to look into studies for the cost effectiveness. If you have, especially in certain populations where HCV risk is particularly high, it might be very valuable to look to using an HCV RNA test as the first line and really only line for HCV diagnosis. We can also look at whether additional sample types would allow for self-collection in settings where maybe trained phlebotomists aren't always available. So looking at rural type settings, what are some of the alternate sample type collections we could potentially consider? Dried blood spots is a great example of this, and we do have some laboratories here in the US that have independently validated use of dried blood spots for HCV diagnosis. Again, this is something that current FDA-approved molecular assays do not have indications for dried blood spot, but something that might be considered for future claims expansion. And we can also look to additional technologies, so rapid diagnostics or point of care. Again, something that is one step, quick turnaround time, something that ultimately you could do testing and deliver a patient result before that patient leaves your clinic. This would also allow for maybe wider access to community where you don't need necessarily a specialized lab with high complexity or moderate complexity molecular testing. So where does public health fit into this realm then of testing? Public health labs really, as I mentioned before, play a critical role in reaching our elimination goals by contributing to confirmatory testing, surveillance, genotyping, as well as drug susceptibility testing. And HCV screening and testing in the United States is primarily done by state and local public health labs. And in 2022, APHL released their HIV and HCV diagnostic survey report for 2019 through 2020. And the survey results report a high level of diagnostic capability among public health laboratories, with more than 50% who participated in the survey that offer HCV antibody testing, and about a third of the labs that participated offer and perform HCV RNA testing. Just under half of the labs that offer HCV RNA testing perform that in-house, and the majority of those already have in place automatic reflex from antibody to RNA. And looking ahead as far as what anticipated changes are, so the majority of labs that responded to the survey were not planning on many changes to their test offerings, with an additional 6 laboratories that were planning to add HCV RNA testing on site. And so as good as the capacity that exists in public health labs or is planned, what we really need to do is to employ more than just public health labs for HCV screening and testing. We really need to use all the resources out there available to be able to reach every single person that we need to for testing. So this includes academic and community-based hospitals. This includes commercial labs, private laboratories, as well as clinics and even non-traditional testing facilities. So one area of focus has been to increase screening and testing in emergency departments. And there are many people here in the US who do not access medical care via primary care providers and may be more likely to seek care in emergency department setting. And this is being recognized as a key target in many states. So for example, in March of 2022, the California Department of Health released important Dear Colleague letters to their healthcare providers in California stating that adults accessing care, whether in the primary setting or an emergency department setting, must be offered HCV screening. In a study that was performed at the University of Pennsylvania Perelman School of Medicine by Mehta et al. And published in JAMA Network Open, found that making HCV screening a default order for patients who present at the emergency department and who meet in the guidelines, as compared to having physicians go in for a multi-step order within their system, they were able to increase their screenings. They were actually able to double the amount of screenings that were happening in the emergency room for HCV. So going from 40% to 80% of the people who should be screened that were actually getting screening. And there's also currently underway the DETECT study. This is a multi-center prospective trial to test the comparative effectiveness of either non-targeted screening versus targeted screening for HCV in the emergency department, with their primary hypothesis that non-targeted screening is going to be superior to targeted screening when identifying newly diagnosed HCV cases. And this is, as I said, a multi-site trial that's going to be performed in emergency departments in Denver, at the Denver Health Medical Center, as well as at Johns Hopkins in Baltimore, and at the University of Mississippi Medical Center in Jackson. Another area where we see HCV screening and testing efforts working is in our correctional settings. So because HCV is readily transmitted through injection drug use, and individuals with substance abuse disorders are often incarcerated, there's a disproportionately high prevalence of HCV in our correctional settings as compared to the general population. And when we look at the large number of incarcerated men and women, most of whom will eventually go back and return to their communities, by incorporating into correctional settings HCV elimination plans, we are able to reduce the burden of HCV both in the correctional settings as well as in our surrounding communities. And oftentimes, correctional facilities, they offer a setting with greater access to health care, improved food and housing security, and so providing care along all of the steps of the HCV care continuum, including HCV prevention, screening, linkage to care, and treatment, this can be optimized potentially in the correctional setting. And the keys to success are really to ensure access to HCV testing by completing the screening as quickly as possible, preferably at their initial health assessment, and ensuring that reflex testing for antibody-positive results that are being done are done quickly. So a project completed by Megan Crumpler and Miriam Zawandi at the Orange County Public Health Department and was presented last year at the Advancing HIV, STI, and Hepatitis Testing Conference, showed the successful implementation of reflex HCV testing in the jail setting. In fact, her data showed a rate of about 22% of the jail population that was tested had antibody reactive tests, and of those, HCV RNA was detected in 57%. So when optimal models of HCV care and treatment are provided to inmates, there is a good chance of cure and success. A study by Hale et al. And conducted a retrospective observational study for the entire population of incarcerated persons in Vermont. This was done from December 2018 through June of 2020. There was a total of 217 patients that had a confirmed HCV infection, and the majority of those also had a liver fibrosis assessment. Of those, 59% started DAA treatment, and just over 50% were able to achieve full cure for HCV. And of the 129 HCV-infected people who started treatment, they had a 92% completion rate and an 86% documented cure rate. And this study really reports the highest HCV cure rate that's been achieved to date in a state incarcerated population, and is, I think, an excellent model for others to consider. Okay, so success for HCV testing does not necessarily have to be a one-size-fits-all. I think when we look at the success of testing for HCV and ultimately then treating for HCV, we really, again, are looking for the right test at the right time, and we need to think about the target populations that we're looking at. So we have young adults, we have regular adults, we have pregnant women, we have incarcerated population, we have people who inject drugs, people living with HIV. We all may need to consider where the best touch points are to reach these individual populations. We also have to think about the service delivery settings. As we look at the different populations, we have different service delivery setting options. We have primary care. We have hospital, whether these be large academic centers, whether these be small community centers. We have correctional facilities. We have outreach clinics. All of these are places that we need to be going. So we need to try to be going to the patient rather than just always assuming that the patient is going to come to us. And of course, too, we need more funding opportunities, right? Recently, APHL had a request for proposal for an initiative with the aim to assist public health laboratories with any aspect of implementation and expansion of their HCV RNA testing in order for them to be able to complete the full algorithm testing in-house and without having to refer to another laboratory for final confirmatory testing or requiring that patients come in for an additional visit or blood draw. And we have congratulate the awardees of this grant that are listed here. Okay, so as I said, the time is now. Cases are rising, and we have excellent diagnostics. We have an effective treatment for HCV, and it's time for us all to act. Organizations, USPSTF, CDC, AASLD, IDSA, all of the guidelines are now well aligned to support broader screening and testing in all adults, in all pregnant persons, and those who are at high risk. Hepatitis C is recognized as a global, national, local levels as a significant public health threat. And elimination goals and plans have been in place and are being revisited and reinvigorated. And really, the road to elimination is founded in testing. Public health and public health labs are the cornerstone for testing and community support, but they cannot do it alone. We need everyone, commercial, private, academic, community, clinics, and other non-traditional settings to all help to achieve this goal. We need to consider what changes to screening and testing need to be made to be able to close the gap and meet our elimination goals. We can all recognize that testing needs to be fast, it needs to be easy, accessible, and cost-effective, but we need our testing options to best fit the populations that we are targeting. And this means that it isn't a single unicorn for our testing modality, but rather we need to consider what do we have now and work on maximizing every opportunity we can to get people tested and into treatment. And at Hologic, we are committed to empowering people to live healthier lives everywhere, every day. And of course, we at Hologic then are interested in what you are all thinking, what are your wants, what are your needs. We are always excited to work with our public health labs in partnership and certainly welcome any thoughts. If you have, happy to talk with you after this session to consider any study ideas and thoughts you may have. So thank you very much.